during diastole, because it gets bled. When we are telling that heart is pumping, it is actually the ventricles are pumping the blood. Okay, ventricles pumps the blood during systole, so the ventricles gets the blood during diastole. That's why the term expansion for diastole. And the time period between the closure of the semilunar valve to the closure of the AV valve means atrioventricular valve. Okay, the valves that are located in between the atrium and ventricle, which are mitral valve and the tricuspid valve, and semilunar valves are aortic and pulmonary valves. Okay, the time period of the diastole is the closure of the semilunar valves to the closure of the atrioventricular valve. So the closure of the semilunar valve means the time where the systole stops. Okay, the time between systole stops and immediately diastole happens, and it extends till the point of closure of the mitral and the tricuspid valves. Now, what is a normal diastolic function? If we are saying a patient has a normal diastolic function, we must have this idea that the patient's LV is relaxing well and it fills adequately and the filling pressures stays normal. There is no hike and or an abnormal kind of filling pressures inside the chambers of the heart, and it is getting enough blood and it also relaxes well. Okay, it's a very it is having this very relaxed state, and only then it gets the blood it actually wanted. That's how it can pump the blood outside of the heart. Okay, so that's a general idea of the diastole. And also one thing, I'm knowing that you guys are all students, so I don't want to be this presentation a very high level presentation. I just want to make sure that whenever you come into the practical aspect, you just have to know that like when you seeing a Doppler display or diastolic things of the measurements that we take on the diastole, I would just want you to be assured of what is the diastolic function of this patient, what is the condition of the diastolic function of this patient. That's what I'm looking after by the end of this presentation. So I'm not getting into very higher level. I am just giving you a basic idea, and I want to make sure you are well aware of the term of the diastole. Okay. Now the second one, diastole. Why so important? Because the 30% of patients with congestive heart failure, patients which having the symptoms of congestive heart failure, do have normal systolic function. That's what I'm saying. If a patient is having a 60% of EF and the patient is having symptoms like dyspnea on exertion or shortness of breath like that, and you must be seeing the patient's ejection fraction is very good, or in normal limits, the patient may have symptoms of congestive heart failure because of its diastolic dysfunction. Okay, so the 30% of patients, this measurements is not a lie. Okay, so the 30% of patients may have diastolic dysfunction and may have normal systolic function. And diastolic dysfunction produces the signs of heart failure. HF means heart failure due to increased left ventricular filling pressures. Okay, if the left ventricle has high filling pressure, the left atrium has to push that much blood at that much high pressure. So it automatically increases the left atrial pressure. Okay, that's how heart failure comes. And heart failure comes just because increase in left atrial pressure is reflected back to the pulmonary circulation. We know that LA, LV, and LA is connected to the four pulmonary veins. So whatever the systems of pressures happening at the left atrium is reflected back into the pulmonary circulation. Okay, so if the patient is having left atrial pressure, it is immediately reflected back into the pulmonary circulation and causes the symptoms like shortness of breath. If the lungs are affected, the patient immediately has dyspnea or shortness of breath and that kind of symptoms. So it are the signs of the pulmonary congestion. So diastolic dysfunction it becomes symptomatic like that. Okay, it reflects on the left ventricular filling pressure, then reflect on the left atrial pressure, and it reflects back into pulmonary circulation. That's how patient develop the symptoms. The symptomatic diastolic dysfunction is also known as heart failure with a P means preserved. Okay, heart failure with a preserved ejection fraction. This patient may have his or her ejection fraction at normal limits, but he's having a heart failure. That's why the doctors will write in the case sheet that HFPEF. Okay, which means heart failure with a preserved ejection fraction. And also there is other term which called HFREF, which means heart failure with a reduced ejection fraction, where the patient may also have the systolic dysfunction. The patient may have reduced ejection fraction also along with the
Yes.
Yeah, fine. Not needed. Just go through it. Okay. Here we are seeing a complete cardiac cycle, and we can see here like the ventricular systole is only this much duration, and the rest of the entire part is taken over by the diastole. And in diastole, there are four phases which we are learning later. Okay. So there is isovolumetric relaxation and rapid filling phase, and slow filling phase or diastasis, and rapid active filling or atrial contraction. And diastolic function, because the left ventricular filling pressure is affected, which we are already talked about, and AV valve function, if the mitral valve or tricuspid valve is affected, or if it is not opening that much, in case of mitral stenosis like that, the diastole is also affected because heart is not getting enough blood. And preload is the conditions which depends upon the heart's getting the, if the atrias is getting not that much of blood or preload is affected, it also affects the diastole. And heart rhythms and rate, if the patient is having atrial fibrillation, the atrias are not contracting. So case of AF patients, so the diastole is incomplete. There will be this much only phases are happening in the atrial fibrillation. So heart rhythms are affected, and rate of relaxation, only the heart relaxes, only the ventricle relaxes very well. The pressures are equalized, and also it gets enough blood. So relaxation rate is very important. And ventricular compliance, because it is an elastic recoiling that helps, like during the systole, ventricles contracts very much and it expands. Okay, so the contraction is very contraction expansion is very important in the case of diastole and atrial systolic function, which we have already talked about. Now, stages of diastole. IVR is isovolumetric relaxation phase. And here we can see. Okay, this is LV. This black line denotes the LV pressures, and the red line denotes the aortic pressure. So here we are saying that the LV pressures are higher than the aortic pressure. So it is this phase the systole happens. Okay, it is the high pressure. It is from the high pressure system the blood pumps. Okay, so from the high pressure LV, heart is pumping the blood into the aorta, which is actually systole. And now the pressure starts to decelerate, like it is rapidly decreasing. And during this phase we can see AC is aorta is closed, because we can see that aorta and LV pressures are almost equal, and with no pressure different, if there is no pressure gradients between two chambers, the valves automatically closed. So aorta is closed, and also the mitral valve is not open yet. MO means mitral valve opening. So the both valves are closed. So this phase is called isovolumetric relaxation, which we have written here. Okay, that's the first phase. And after that, early rapid filling phase. Now we can see this blue line, which is left atrial pressures. Okay, and we are seeing this from this phase, left atrial pressure take over the left ventricular pressure. So the valve opens, because there is a pressure difference between the left atrium and the left ventricle. So the mitral valve is open right now, and blood starting pumps. Because of the pressure difference, the blood is pushed into the left ventricle. So that's how the E phase is called early rapid filling phase. And now the pressures in between the left atrium and left ventricle is almost, they are fighting for each other for their existence. So there is still a little wind on the left atrial side, so the blood is actually going through the atria to ventricle, but still it is a plateau stage. So that's why it's called a diastasis, or slow filling phase. And now the atria contracts, and we are seeing here a P wave in the ECG. This is the ECG right now. So the P wave is actually the atrial contraction phase. So atria contract, and there is active filling, and blood, a little of the blood also get into the ventricle from aorta, sorry, from the atria. So that's the four phases of diastole, which is isovolumetric relaxation phase, early rapid filling phase, diastasis, and atrial filling phase. All the 1, 2, and 4 was very important in case of diastolic function. So we have to discuss about it later in the session. So next. Isovolumetric relaxation phase. Okay, it occurs immediately after the ventricular ejection. We have seen that the aorta is closed, and now systole is almost at the is almost over, and now isovolumetric relaxation phase happens. This is the phase where left ventricle relaxes. So we are seeing the pressures are falling very rapidly during the isovolumetric relaxation phase. So both the valves are all closed, and this is the phase of myocardial relaxation. The pressure within the ventricle decreases very rapidly. it falls very rapidly. That's why this decline. And the LV volume remain constant, because we know that the both semilunar valves and the AV valves are closed right now. No filling or no emptying is happening as in this phase. So the LV volume remain very constant. That's why the name isovolumetric. Iso means same. Volumetric means volume. So in this phase, the volume remains constant and depends upon the loading condition and by age. Okay, age also reflects the isovolumetric relaxation phase, which we'll be discussing very later. So here we are seeing an echo image of the patient, where we have put the pulse wave Doppler in the typical 4-chamber view, and we are seeing a spectral Doppler display. This is what we call a display. This is a spectral Doppler display, and we are seeing an E wave and an A wave. E wave denotes the early rapid filling, and A wave denotes the atrial filling. And here we are seeing a little whitish area. Na? This area is called the systole. We are not seeing that much because we are mainly focusing on the mitral inflows. This is called mitral inflows. Okay, E and A is called mitral inflows, and this is the systolic phase. And we are seeing these 5 dots here. 1, 2, 3, 4, 5, 6. Actually 6. Okay, this is called the IVRT, and a little blackish color area, that's called the IVRT. This is a phase where left ventricle actually relax. This we usually measure this time period by caliper or by time caliper, and this value is very important in case of the diastolic function of this patient. So here we can see this is systole of the patient, and we from this point to this point. Here aortic valve is closed, and here mitral valve is open, and in between this phase is called the IVRT, which is the isovolumetric relaxation phase, followed by the E wave. Now, early rapid filling phase. Okay, following the IVR, which means isovolumetric relaxation, LV pressure falls below the left atrial pressure. We have seen here the LV pressure falls. The black line is falling behind the blue line. So the pressure inside the atria is higher than the ventricle. So the blood is pushed back into the system. So mitral valve opens, and normally 80% of the LV filling occurs during the early rapid filling phase. So if the diastole has given us 100% volume, the 80% of them, which means a majority of the blood, is pushed into the ventricle by this phase, and it is represented as an E wave. Here we saw a E wave, and this is what happens in the early rapid filling phase. And the rapidity of the LV filling is reflected as a rapid and steady fall. This rate of decline is called deceleration rate. Now we have seen here, from this point the pressure start to decrease, so it falls back to the baseline. So this rate is called the deceleration rate, and we measure from this point, from the peak of the P wave point to this point where it get merged into the zero baseline. That time is called deceleration time, which is also another important dimension in the case of diastolic function. We have to measure it. We have to take the caliper option, and we have to click here and measure what millimeters of seconds it is taking, and it is an important criteria in case of a diastolic function. So the rapidity of the LV filling is reflected as a rapid and steady fall, and this rate of decline is called deceleration rate. Time between peak of the E wave to the point of deceleration extrapolated to the baseline zero. The extra word you have to avoid it. Just a textbook method word. Okay. So from the point of the peak of the E wave to the time which it merged into the zero baseline, that's what it is called the deceleration time. And normal deceleration time is 160 to 240. Okay, if the patient is having a if we are measuring and we are getting a value between 160 to 240, we can say that it's a normal value. If it falls beyond that and below that, it's an abnormal value. Now diastasis is not that much taken care in case of diastolic function as an echocardiographer point of view. Anyway, it cannot be avoided because it's actually part of diastolic function. Okay, so LA and LV pressure begin to equalize. We have seen here the two of them are fighting for each other for their existence, and they are almost maintaining an equilibrium right here. But still, left atrial pressure is taking a little step ahead, so the filling is happening. The red flow denotes the filling, so it is actually a plateau stage where filling is happening. So LA and V pressure begin to equalize, and in bradycardia, if a patient is having a bradycardia, it takes a longer time. So the longer time is reflected on the diastasis time. So longer period of diastasis will be there, and in tachycardia we will be seeing a totally absent diastasis where E wave and A wave come nearly merged together, like they will be very close together, and it is visible as a low and uniform velocity close to the baseline, which we have already seen. Now, atrial contraction, following a P wave, the atrium begins to contract, and thus there will be a small increase in the left atrial pressure, and LA and LV pressure. LA pressure will exceeds a little bit, and blood is pushed into the LV. It is an active phase, so the blood is pushed into the LV, and it take up 15 to 20% of total LV filling. We already told that 80% of the filling happens during the early rapid filling, and the rest of the filling happens in the atrial contraction time. And it is represented as a wave of the spectral Doppler display. We have seen here the A wave, which is actually the atrial contraction. So from here to here, the diastole exceeds, and it is actually a iso-1-way relaxation phase, then earlier rapid filling phase, then a diastasis phase, and after that an atrial contraction phase. That's the stages of diastole. Is that clear? Are you sleeping?
Yes.
Are you clear? Okay. I'm taking the silence as a yes. So you're all listening. Okay. So now we have studied about the diastole and its stages, and now we are a responsible echocardiographer, and we are sitting with a patient on your side, and the doctor says, the cardiologist came to, and saying to you that, Hanana, please find the diastolic function of this patient and what all the measurements you will be taking for this patient, and this is how I do it. Okay, so first we have to take a apical four chamber view. FOC means an apical four chamber view, and this is the actual apical four chamber view for a patient if you are getting if you place the probe at the apical position of the patient. So here we are seeing a cursor. Okay, this cursor is aligned at the tip of the mitral valve. Okay, and you are seeing this point now, these two lines. This is called the sample volume, and you have to place the sample volume at the tip. Okay, if you are placing it here or if you are placing it here, it will give an incorrect value. If you are placing it here, we will get a wave which is very superficial, and if you are placing it here, we will get a E wave which is very superficial. So it is very important, you have to place it right between the mitral tip. Okay, and the sample volume, we can adjust the sample volume length. Okay, it should be a 3 to 5 mm. Oh, sorry. Okay, so we should take a typical four chamber view, and we can use a color Doppler. It is not very mandatory. Anyway, for optimal alignment, you can use a color Doppler so that we can see the correct flow through the mitral valve. And you should place a cursor, which should be a pulse wave Doppler. We can use a continuous wave Doppler, but for much more accuracy, we should use a pulse wave Doppler. And the pulse wave Doppler is placed in, one second. The pulse wave Doppler is placed in between the mitral tip and the sample volume, which is the distance between the these two lines. This is should be a 3 to 5 mm, which we can set in the machine settings. Okay, the machine have the settings of to adjust the sample volume. If you are noticing that, so it should be set between 3 to 5 mm and lower the zero baseline. So if you are, here is a baseline, and we can shift the baseline. We're using a baseline option in the knob. Okay, so lower the baseline, and sweep speed is set at 100 meter per second. So we use a sweep speed which is 100 to measure it very accurately. The sweep speed, as higher the sweep speed, higher the accuracy. Like the display will be very shorter. Like we will be seeing very accurately. So that's how we do it, and we will get a spectral Doppler display like this or like this. E and A will be seeing, and we can measure it, which we'll be talking later. Okay, by using the measure option, we will see a mitral valve inflow velocities, and we can measure the E velocity, and we can measure the deceleration time, and we can measure the E and A ratio, E by A ratio. Okay, that's what we get from this entire image. Okay, from one single image of mitral inflow, we can get this much of values, like E velocity can be measured, and deceleration time can be measured, and the ratio of E by A can be measured. That's we have shown here. E by A ratio is the E wave velocity divided by the A wave velocity, with which the machine automatically detects. Okay, that's the use of the technology. Anyway, next one is the doctor says, okay, you have done very good job at the transmitral inflow. Now, what you do next? Okay, this is what I do next. From your machine settings, you should take a TDI preset. We will take the same view. It is only the apical four chamber view again, and we will take the TDI option. Some machine have TVI. So depend upon your machine, you should take the TDI preset, which will be displayed like this: a green, a blue, and a red color display into the myocardium. It is used for detection of the low velocity signals, like myocardial velocity signals is measured right now. TDA actually means tissue Doppler actually velocity, which is known as I means index. Okay. So TDA preset we are taken for the low velocity signals, and again the pulse wave Doppler is used, and the volume is 5 to 10 mm. Okay, earlier we discussed the sample volume is 3 to 5 mm. Automatically the machine take out 5 to 10 mm for the TDA present preset. You don't have to change it if needed. So, and we have to take at the septal and lateral mitral annulus. Okay, earlier the transmitral inflow we place the sample volume between the mitral tip. Here we have to place at the annulus. This is the mitral annulus. We are seeing a apical four chamber view. Okay, and this is the tricuspid valve, and this is the mitral valve, and here it is the lateral. The lateral side means heart outer side. Okay, outer side is the lateral annulus, and this is the inner side between the septum. So this is the mitral septal annulus, and we have to take both values. We have to take from the lateral annulus, and also take from also shouldn't take from the medial annulus also, between the septal annulus also. So we will be getting a Doppler display like this, which will show a upper wave, which is called a systolic wave. Okay, here we see only two waveforms, one E wave and A wave, and also sometimes we will get a downward wave, which is a S wave, and again a E wave and A wave. Here the E and A are inverted because the in myocardium it moves opposite to the blood flow. It moves inside during the systole, which will be showing as a forward flow, and during diastole it relaxes back. So it is shown as a downward wave, like a downward deflection. So E wave and A wave is shown below the baseline. So don't get confused between. In transmitral inflow, we will be seeing an upward above the baseline, and in TDI we will be seeing lower the baseline. So we will be getting an S dash wave, an E dash wave, and A dash wave. Okay, that's how we will see. Excuse me. Okay, so the angle of interrogation should be as parallel as possible. It is very important, because if we are placing the apical four chamber view shifted to here, like we will be seeing the window as here, it will misunderstood the value. So you should be very careful in the alignment of your view and the alignment of the cursor. It should be as parallel as possible, and at this zero baseline it should be middle, and it should be the sweep speed should be 100 millimeters per seconds. Okay, now left atrial volume index. So we can get the left atrial volume from both the apical four chamber view and also from the apical two chamber view. Here we have shown the images from that we have measured it from the apical four chamber view. The same method can be used for the apical two chamber view also. So you should be optimized for LA, which means you should take you should be seeing the pulmonary veins which should be draining into the LA, and you should see the very correct position of the mitral valve. It should not be foreshortened. Foreshortened means if the ventricle is shifted and the atria is you should not be seeing the correct size of the left atrium, so it will reflect on the measurements that we will be taking. So you should optimize for the LA, and acquire and freeze the end systolic frames. Okay, you should freeze at the end systolic frame, which will be a T wave in the ECG. You should stop the cursor. You should move the you should press the freeze button and move the cursor trackball, and now freeze at the end systolic frame, which will be corresponding to the T wave in the ECG. And now, wait a second, please. Excuse me. And now we can use multiple methods for the measurements of the left atrial volume. Here we have used a Simpson's method, which will not be available in the older machines, but now we have this option in biplane. When we take the echo settings, we will see a biplane method, and from there we can trace. You should click it here. Okay, you should take the cursor and click it here. Now go and trace whole of the left atrium, and you should be taken care of that you should not be measuring any pulmonary veins. You should not be going like this. Like this is a pulmonary vein now. We should not be going like this. You should only track the endocardium of the left atrium. Avoid the pulmonary veins and also the left atrial appendage. And now you go here and you end up here. Okay, you begin here and you end up here by tracing the whole left atrium, and now you click there and this line automatically shows up and it will track it. And this is the method of Simpson's, which means the left atrium is cut into multiples of disk, and it is automatically calculate the left atrial area during the apical four chamber view, which is a 17.9 centimeter square. This value is divided by the body surface area of the patient, and now we will get a left atrial volume index, and the unit is milliliters per m cube. Okay, and the abnormal value is will be if you are getting a value which is greater than 34, it will be an abnormal value. Only below the 34 will be the normal value. If it is above the 34, the pressures inside the left atrium is higher. That's why it reflects on the dimension. So this is a method. Or otherwise, one simple method is if your machine is not having a Simpson's method, you can simply take the trace option from the trace or area option from the settings, and you can just trace the whole left atrium complete here. Earlier we click from here and stop clicking from here. In case of area tracing, you should be stopped at right back on the beginning point. Now you get the entire area of the left atrium, and the volume is automatically calculated here. It is 57 and 49 ml. Now the value is divided with the body surface area. You will get the left atrial volume index. And also there are other methods called the Prolate ellipse method, where we will be calculating the taken measure from here to here and from here to here. There are the two dimensions. You just simply take the caliper and click here from here. You will get one value which is D1, and you will get here from here which is the D2 value, and this is multiplied by the left atrial dimension, which we will be taken from the Plaque's method also, and all three multiplied and multiplied by the 0.523 will also give a left atrial volume. So there are multiple methods. So you can use the inverse method. I think this method is actually calculated by the machine itself. So we rely mostly on this. Now the peak TR velocity. TR also very important in case of diastolic function. As we know, from TR velocity we can calculate the right ventricular systolic pressure, which is actually in case of no right RVOT obstruction or like that cases, it reflects the pulmonary artery systolic pressure. So in the beginning we have already talked about how the left atrial pressure reflects back into the pulmonary circulation and how it affects. Likewise, the TR velocity depends upon gives an idea about the diastolic function. So aligned parallel to the TR jet in any view. So we can see the tricuspid valve in parasternal long axis RVOT flow, RV inflow view, and we can see it in the aortic short axis view, or also in the apical four chamber view. So from any view that you are comfortable or any view that you are getting a clear view, you get aligned the TR jet using a continuous wave Doppler. Earlier we talked about pulse wave Doppler. Now we have to use a continuous Doppler because a TR velocity is something which have a greater velocity. It is a higher velocity. For higher velocities, you should be using a continuous Doppler. The transmitral inflows and the TDI velocities are all very low velocities. They barely goes up to 2. Okay, they barely go up to 1.6 or something. If the patient is having higher grades of diastolic function dysfunction, or the patient is having a mitral regurgitation, only then the velocities goes up to 1.5, above 1.5. So in all other cases, it always stands below the 1.5. So you should be using a pulse wave Doppler in that cases. And here he will be getting a higher velocity. So you should be make sure that you use a continuous Doppler. And now adjust the zero baseline. You should be for seeing the entire spectrum. You have to adjust the zero baseline and move to upward. And sweep speed should be 50 to 100 m per second. And abnormal value is greater than 2.8 millimeter per second. If you are getting a velocity which is greater than 2.8, it is an abnormal value. So it denotes a diastolic dysfunction. Now it is a higher level thing, pulmonary vein inflow. So yeah, here we know this is apical four-chamber view, and in this view we can see three pulmonary veins which actually drain into the LA. Here will be the one, and here will be the two, and there will be one here also. So this is the right upper pulmonary vein, this is the right lower pulmonary vein, left upper pulmonary vein, and this is the left lower pulmonary vein. So most ideally we should be using this pulmonary vein and this pulmonary vein for the pulmonary vein inflows. So what should we do? We take a apical four-chamber view and we will place a sample volume which is 3 to 5 mm. The distance between the two lines are called the sample volume, and which we will be placing at a 3 to 5 mm and placed approximately 5 to 10 mm into the right upper and right lower pulmonary vein. It should be at least at 5 to 10 or 1 centimeter into the pulmonary vein. And now you have to adjust the zero baseline, and the sweep speed should be 100 meter per second, and you will be seeing a display like this. Okay, this is a very difficult thing to get. Actually, you will not be seeing this very often. You should be very practically acknowledged to get this one. So you will be seeing a S wave and a D wave and a small lower deflection which is called the atrial reversal, which is written as a AR. So S wave, which means a systolic wave, and D wave, which means a diastolic wave, and AR is actually followed by the P wave. So atrial contraction phase. Okay. So and you should be taken care if the patient is having an S wave which is lesser than the D wave. If this patient is almost have the same values for the S and D, which is actually normal. If the patient is having a lower S wave and a greater D wave, okay, a small S wave and a very and a big D wave, it is an abnormal. Okay, S less than D, it's an abnormal value. And if the air velocity is greater than 35 meter per second, if we are getting this thing now, this small deflection velocity, if we measure the velocity and it is giving out a value of greater than 35, it is also abnormal. And AR minus A wave duration. AR means this duration, from the point this from here to here, this is the AR duration, and AR duration is subtracted with the A wave duration. A wave duration is this duration, the A wave from the transmitter. We should take the values independently. From the transmitter flow, we should take it. We should measure from here to here for the A wave duration, and for the from the pulmonary vein inflow, we should measure this one. And if the subtracted value is showing a value greater than 30 milliseconds, it is also abnormal. So the three things that we get from a pulmonary venous inflow are if the S is less than D, if the AR velocity greater than 35, and if AR minus A wave duration is greater than 30, it will give out a diastolic dysfunction for the patient. IVRT we have already told, we have talked so many times. So from the apical four-chamber view, you should take a continuous wave Doppler, and it is cut through the LVOT and with the end of the aortic junction, and from the onset to transmitral inflow. So we have already talked about it. It is a systolic flow. Here the aortic valve closed, and here the mitral inflow starts. So the distance between from here to here, it is called the IVRT. And you should use a low wall filter. So it's a very minute thing, so we can miss that thing very often. So you should use a low wall filters and zero the baseline, and sweep speed should be adjusted for 100 meter per second, and we can measure it. And also we can also take the IVRT from the TDA, also from the tissue Doppler velocity also we can get the IVRT. Here from the this will be ulta of the transmitral inflow. The S wave we will be seeing at the above the baseline, and the E wave of here will be seen as here E dash, and A dash will be followed by that, and in between S dash and E dash we will be seeing this little thing, this little two lines now. In between that is the IVRT. So we can measure it by using a caliper, time caliper from the machine settings. Please click here and also click here, and you will get a value. And here the machine is showing us 71. If the patient is having a value between 70 to 90, it will be normal. The patient has 71 as IVRT, so it is a normal value for the patient. Now, Valsalva maneuver. Valsalva maneuver is very critical in the case of grade 2 diastolic dysfunction. So, here we take the settings as same as of the transmitral inflow. Like we have already discussed, you should take a apical four-chamber view, and you should take the pulse rate Doppler. You should place it between the tip of the mitral valve, and you will get a spectral Doppler display like this. Now, you should instruct your patient. You should tell your patient that to bear down against a closed glottis, which is actually we actually instruct the patient as to try to breathe by closing your mouth and nose. Like please close your mouth and nose and try to do a deep breathe. Or sometimes our doctors used to take the bulb of the bulb of the BP apparatus, and they will instruct the patient to blow very hardly into the bulb, and that's how also we can do the Valsalva maneuver. So there are multiple steps for each cardiologist to do a Valsalva maneuver, so that's how we do it at our institution. So you should instruct the patient to close his mouth and nose and try to do a deep inhalation. So that's how we do it, and we should record it for 10 to 12 seconds continuously. You should be recording and the spectral Doppler display continuously, and the sweep speed should be adjusted for 50 millimeters per second. That means the spectral Dopplers are very closely aligned. The speed is very higher. In this case, this is the same patient. We have put the Valsalva. So here we know that E wave is higher than the A wave. Now we have instructed the patient to do the Valsalva, and look at this. What happens here is E wave is reduced. E wave is smaller, and the A wave is the bigger one here. So there is this reversal of the EA by Valsalva. So this patient is having actually a grade 2 diastolic dysfunction, which we will be taking a notes later. So this patient is having a grade 2 diastolic dysfunction, which actually looks like a normal spectral Doppler display at rest, and we are taken a Valsalva maneuver, which will shows that the patient is having actually a dysfunction. So in patients which we are doubtful about having a grade 2 diastolic dysfunction, you must do a Valsalva maneuver to look after the EA reversal. That's about the Valsalva maneuver. And color mode VP, which is also a higher level thing, but you should be well aware of it because it's very crucial in nowadays. So here we do a apical four-chamber view, and you should put the color Doppler, and now place the M mode cursor. M mode cursor you should take from the machine settings, and you should place it here. Like you are seeing this little yellow dot line. This is M mode cursor, and there we can see a apical four-chamber view. The color is on, and the color sector is adjusted from the apex of the patient to the mitral, below the mitral valve. Okay, the color sector should be as big as this much. It should be from the apex to the below the mitral leaflet. So and M mode cursor is placed between the mitral tip, and we will get a display like this. Immediately we will get a display like this. Here we are seeing the excursion of the mitral valve annulus, and also this is the blood flow. Okay, the red flow we are seeing here is the blood that going from the left atrium. This is the left atrium and goes into the left ventricle. So this is diastole happening here actually. So this is the early diastolic filling phase, and the small red one is the atrial filling, and this is the phase of diastasis. Once again, I will repeat it. You should take a apical four-chamber view. Now you place a color sector which should be from the apex to the below the mitral annulus, and you should place a M mode cursor, and we will get a display like this. Okay. Now the from this point of the peak of the excursion, you will get the early rapid filling phase. Now followed by a atrial filling phase. E wave in the E wave, the corresponding reflection to the E wave and the corresponding reflection to the A wave. Now, lower the Nyquist limit either by decreasing the color velocity scale or moving the color scale upwards by the direction of the mitral inflow to enhance the early diastolic slope. Okay. So we are seeing something here now. This is the velocity range. Here we are seeing a minus 61 and we can adjust this. Okay. If we are given a value of minus 31 here, we will add a Nyquist. We will artificially add a Nyquist, artificially add the aliasing to this display so that we will can identify the slope of the early diastolic filling phase very clearly. Here in this image, it is not done. The aliasing is not done actually. So if you are here, otherwise also it can be well visible here. That's why maybe they haven't done that. So if you are a beginner, you should be shifting the baseline into minus 30 or minus in between minus 30 to minus 40, and you should measure from here to here along the tangent of the slope. You should measure it and you will get a value here which is 59.9 slope. Okay, and also should taken care the distance of this line. This line should at least have a value greater than 4 to 5, in between 4 to 5. Okay, at least greater than 4 you should be taken care of. Okay, so first thing is you should taken a color Doppler, and now you put a M mode and you should measure from here to here and make sure the distance is greater than 4 and you will get the slope which is a 59, and the abnormal value is less than 45. Okay, if the value is less than 45, it's abnormal value. So here the patient is having a normal diastolic function. Now, likewise, the TR velocity, we can also use the PR end velocity here. Align any views, any views with PR jet and use a convex Doppler, and should be parallel to the PR. Here, this view is actually pulmonary bifurcation view in the apical parasternal short axis, and we have placed the pulsate continuous Doppler at the or if at 1 centimeter above the pulmonary valve. So adjust the zero baseline, sweep state should be 100, and what you have to take is this is the pulmonary regurgitation spectral display. Okay, this is actually the pulmonary velocity, the flow which goes into the pulmonary artery, and here the regurgitation which is shown upward. Okay, because this is a valve. Okay, and the pulmonary artery is here, and the normal flow should be from here to here, which should be downward the baseline. And if the patient is having pulmonary regurgitation, the blood goes back into the RVOT like this to upwards. So that's why we are seeing a upward display for the PR. So yeah, this is the end velocity for the PR, and you should measure it using a caliper. And if the value is showing a greater than 2.2 meter per seconds, it will be an abnormal value. Now, the main topic of the one of the main topic of our webinar, which is LA strain. Okay, LA strain is given very important very recently, and it gives out a value which is a very predictor for dysfunction. So if the patient is having any kind of dysfunction, but it is not visible in the normal cases, LA strain should be gives out a clear value. So what should we do is use apical 4-chamber view and apical 2-chamber view. You can use both the views, and or otherwise you can use only one. Okay, so please make sure that it is not a non-foreshortened view. Okay, you should get a clear display of your LA like this, and now decrease the gain to optimize the clean blood pool and LA tissue border and minimize the artifacts. So you can shift the gain, and a much more darker blood pool, like a blackish color inside the LA should be given to identify the clear borders of the LA, and narrow the image sector for optimal frame rate and the good quality ECG. The ECG should be there, and you should adjust the frame rate. If the frame rate is higher, that much and also optimal frame, not that much, very much higher. I think a 40 to 50 frame rate is ideal for the LA strain, which we can be adjusted by the machine. So, and also a narrow image also taken care of. So you should not be have a wide sector image. Narrow sector means we can also use a sector like this. only seeing the LA and LV likewise also. So use a 3 to 5 cardiac cycle acquisition, which will be taken care of the machine itself. If you should just press the aqua button and the machine will automatically take a 3 to 5 cardiac cycle. And now use a dedicated LA strain software to track the LA in both views. So your machine should be should have the software to detect the LA strain. Only in the higher end machines have the LA strain software. I think your hospital has that software as far I know. So use a dedicated LA strain software to track the LA in both views. While talking about tracking, you should be taken care of to exclude the pulmonary veins and LA appendage. Here there is an LA appendage. You should not be taken that into account. Okay, you should only use the borders of the LA. So exclude the pulmonary vein and left atrial appendage and confirm tracking on the other side of the underside of the each analysis point. So you should click here and you should click here, and now automatically the tracking happens. Almost all machines have AI, so the AI will actually do the automatic tracking for you. If you want any kind of adjustment, you should do it. Okay, otherwise you can go with the AI tracking. Now that's how we do it. So apical 4-chamber view, apical 2-chamber view, and you will should make sure a non-foreshortened view. If it is foreshortened, it will give out a misunderstanding value. So that's how that's why we state about we should have a non-foreshortened view. And decrease the gain and narrow the image sector. Use the optimal frame rate, which is actually 40 to 50 frames per seconds. And now a good ECG should be there, and the 3 to 5 cardiac cycles should be acquired, and use a LA strain software. And while tracking, please make sure you are not taking the pulmonary vein and left atrial appendage into the tracking. So that's how we do it. And okay, some bits of LA strain. So we are talking details about the LA strain. What is an actually we are given out in a LA strain view. So LA strain imaging is divided into 3 phases. There will be 3 phases for a LA strain according to the stages of the cardiac cycle. Okay. So first phase is reservoir strain. In this strain, the LA gets the blood from the pulmonary veins. So which is characterized by the LA filling. LA is filled during the systole. So while the ventricle is pushing the blood into the aorta or great arteries, the atria are filled by the veins. Veins actually, LA is filled by the pulmonary veins, and the right atria is filled by the systemic veins. So here we are talking about the LA strain. So LA is filled by the pulmonary veins during the systole. This phase is called the reservoir strain. So left atrium enlarges during this time because it is getting blood and it is actually bulking up. So that's why this positive strain. So we are seeing here left atrial strain. R means the small r means the reservoir strain. So that's a time which most deflection in the LA strain. So it is a very important value actually. So far we are more discussing about the reservoir strain alone in the case of LA strain. The other two are not accounted that much as the discovery. So reservoir strain is very important, and if the value is less than 18 percentage, it gives out an abnormal value. So if the reservoir strain is giving a value of less than 18%, the machine automatically calculate the value. You don't have to take in, you should not be worried about that. So if the value is less than 80%, it's an abnormal value. So here we can see the left atrial strain during the reservoir phase is 23%. So this patient is having a normal reservoir strain. And conduit strain is the phase which happens during the early LV diastole, where the atrial rapid filling, E wave happens. Okay, early rapid LA diastole, the LA deforms and it actually passively filling the LV. The blood goes passively because of the pressure difference from the atria to the ventricle. So the LA strain is lowered because LA is pushing not pushing, the blood from the blood in the LA is going outside into the left ventricle. So the deflection is coming back, coming downwards. So this phase is called the left atrial strain during the conduit phase. Okay. Now the booster strain is happen while during the atrial contraction. So which provides an important information on the left atrium during the left atrial systole. which means the atrium is contracting, which corresponds to transmittal inflow of the A wave. Actively LA is filling. So this is the booster strain, and which is this phase. Okay, this is the left atrial strain during the booster phase. But as for the studies are going on, we are taken care of the left atrial reservoir strain more seriously. Like it gives out the value much more importantly. Okay, now LA strain is a measure of the LA deformation during the cardiac cycle. It has three phases: reservoir strain, which is the strain during the LA filling during systole, and conduit phase is a passive LV filling during the early diastole. During the E wave, the LV is passively filling, which is the conduit phase, and the booster phase LA kick, which means LA is contracting during the late diastole, which is the booster phase. And pathophysiologist, LA is a thin-walled structure which is very sensitive to the chronic pressures and volume changes, which may reflect the subclinical changes prior to the cardiac chambers. Even the pressures are even the like we were doing an echo of this patient, and he's getting the values very normal limits, but still the LA is very sensitive, and it shows the changes, very chronic changes to the pressure and volume changes. So it is a very sensitive. So before it reflects in the transmittal inflow or TDI, we get the reflections in the LA strain. That's why it is very important in this current scenario. So before any prior changes into the cardiac chambers, LA strain gives out the clinical output of how it is going with the LA. So, what are the clinical applications for hypertensive patient? If a patient is a hypertensive and the LA strain predict the left atrial enlargement and left ventricular hypertrophy value, and if the patient is having atrial fibrillation, it will give out the patient who are at the risk of AFib. The patient who are at the risk of the AFib, we will get a normal LA volume and LV function. And if the patient is having heart failure, heart failure with preserved ejection fraction, we will get a similar diagnostic accuracy. If the patient is having reduced ejection fraction, he will the LA strain will gives out the idea about who are all which are the patients we can improve the ejection fraction by pharmacological measure, and which of the patients cannot be improved by the pharmacological agents like that. So in the valvular cases, it will give out the survival rate of the severe MR. If the patient is undergoing any surgery or somewhat, we will take the left atrial strain for this patient, and if the value of the reservoir strain is higher than 18, it will give a good mortality. It will gives out an idea about the mortality prediction. Okay. So also in the case of aortic stenosis also, and in the case of hypertrophic cardiomyopathy, it will give out the major adverse cardiac events. The chances of major adverse cardiac events like a sudden cardiac death or anything for these patients can be given out by the LA strain. And in amyloidosis patient, if the cutoff value is less than 13.3, it will predict the overall mortality of the patient. It will be very critical for this patient with amyloidosis if the value is having a value less than minus 13.3. That's about left atrial strain. Okay, now we are almost at the end of the stage, which is the stages of the diastolic dysfunction. First one is the impaired relaxation. So we have talked about diastolic function of the patient, and we have talked about what are the stages of the diastole, and we have talked about how we will measure the diastolic function of the patient, what all the measurements you should be taken care of in case of a diastolic function if you are getting a patient to do an echo. So if you have collected all these values, and now you have to categorize the patient into one stage. Which stage of his diastolic function is he right now? That's what we have to do next. So what are the stages of the diastolic dysfunction? So first one is the impaired relaxation. Here the patient starts showing symptoms like not relaxing well. The heart is the LV is not relaxing well, and it having some loss of elastic recoil. It is not expanding that much, and it is not relaxing very well, and started to show some symptoms of like not the clinical symptoms but some inside symptoms of diastolic dysfunction. So here the loss of the elastic recoil of the LV during the early diastole. The patient's LV is not relaxing very well, so the there will be a reduction in the force that in blood for that the blood is sucked into the LV through the mitral valve. So the earlier we have seen the pressure display where left atrial pressure exceeds the left ventricle very fastly. So the blood is pushed into the left ventricle very fastly as far the mitral valve opens. But here there will be a reduction in the force of blood sucked into the LV. The delay in this relaxation, the LV is relaxing very slowly and the pressure is dropping very slowly. It is reflected as a prolonged IVRT. The IVRT is little longer in this patient. So we earlier discussed about the normal value of the IVRT, which is actually a value in between 70 to 90. So if a patient is having an impaired relaxation, the IVRT value will be longer. This phase will be much longer here in the case of impaired relaxation. So the decrease in the suction due to the decreased pressure gradients between the LA and LV. The pressure difference between LA and LV is very low. So there will be the blood is pushed very slowly into the left ventricle. So there will be reduced E velocity. E velocity will not be that much higher. It will the amplitude of the E wave is very small. And also the rate of the deceleration also diminishes. So the pressure difference between the both chambers are very slow. The deceleration of that is rate of the decline of the pressures are very prolonged. So DT's deceleration time is also prolonged and the slope is reduced. Now there will be increased atrial preload, and because the blood is still pulled, like the blood is not gone into the left ventricle, so it is getting pulled into the left atrium. So the atria has to contract very much and push the whole blood into the left atrium during left ventricle during the atrial contraction. So there will be a very forceful atrial contraction. So the A wave is actually increased. So we will be having a small E wave and a bigger A wave here. And also the pulmonary venous flow, the pulmonary Dopplers and the E by E dash, all values will be normal and also consistent with the normal filling pressure at rest, because the LA is not affected here. Only the left ventricle is not relaxing. The left atrium is more or less very normal person right now. So it will not be reflected in the pulmonary venous flow, so that it will be very it will mostly normal at normal limits. And also the clinical condition of the patient is he will be asymptomatic at rest, and there will be dyspnea on exertion. If we will be climbing a step or have went for a running or a marathon something, he will be having a dyspnea, but at rest he will be asymptomatic. That will be the symptoms of the impaired relaxation. So if a patient comes to you and tells that he's having difficulty in climbing the steps or somewhat, you should take care of the diastolic function of this patient. Okay. Now pseudo-normalization, which is actually the grade 2 diastolic dysfunction. So here there is this further deterioration of the diastolic function. The relaxation is decreased. There will be chamber compliance, and it is also decreased, and there is stiffness in the left ventricle. So it all affect the relaxation. So there will be delay in the relaxation. So LV's condition is getting deteriorated, but at the same time here the atria try to compensate. Okay, the earlier we told you that the left atria pressure is almost in normal limits, so it is not affected right now. But here from the very next stage, the atria try to correct all the things, and he tried to make sure the relationship goes well. So he tried to elevate his pressure. He tried to become a high pressure system. So the diastole depends upon an active relaxation. So it start to push the blood into the left ventricle. Okay, it try to make the pressure very much higher from my side. I will try to solve the problem from my side, even if he's not cooperating. So he tried to increase the pressure, and there is this increased mean atrial pressure in the atria, and he started to push the blood rather than pulling. Earlier in the normal functioning case, the atria tried to pull the it takes the blood actually normal, like a passive feeling. Here he have to actively push the blood into the left ventricle. So as a result, as the atrial pressure is elevated as in the case of a decompensation, there is shortened IVRT. The LV is not relaxing very well, but still atria tried to make things work, and he tried to push before that. So the IVRT is shortened, but E wave is restored back. this is very important. You should know the reason for this, because the atria try to compensate. We have already told you that it is from the high pressure system, the blood goes into a low pressure system. Okay, so we know that the LV's pressure is higher because it is decreased. It decreases compliance. It has this increased stiffness, and so the ventricular pressure is very higher. But the atria try to brings up more pressure within himself so that he can push the blood into the left ventricle. So because of the pressure difference, E wave is restored back. So it looks like a normal state, like normal waveform. That's why the name pseudo normalization. It's actually a false normalization. It is faking it. Actually, it is not actually a normal state, but it is actually faking it. So the pulse wave Doppler actually shows the diastolic dominance. The S wave reduces and the D wave increases. So the abnormality is here also. And clinically, it is showing a mild to moderate symptoms, and dyspnea on exertion is very common. And the last stage is the restrictive filling, which is actually also known as grade 3, and also a subcase of grade 4 is happening here also. So this is the restrictive filling. The increasingly abnormal LV compliance, chamber compliance is happening, and to maintain the forward flow, LA pressure is continuously increasing. He is trying very hard to work the relationship, but he's not meeting the ends. So the IVR is very shortened, but there is markedly increased E velocity. So because of the high pressure system in the LA, he tried to increase as much as of pressure and try to push very hardly, and so the E wave velocity is markedly increased, but the LV is not cooperating. He is not ready to continue the relationship, so he's much more increasing this pressure inside him. So it leads to a rapid equilibrium, because of the non-compliance in the LV, the equilibrium is attained very fastly in between the LA and LV. The LA and LV pressures are equalized. Equilibration means the pressures in between the both system are equalized very fastly, and so that the E wave stops very fastly. E wave, the flow stops abruptly because of the pressure equalization. Because of that shortened DT, and mitral A wave is also reduced because LA cannot, he have already given all his strength to push the blood, and he is not getting to contract because the pressure inside the LA is very high, so he cannot contract very well. So the mitral A wave is also reduced. And now we know that if consider LA is connected to LV and pulmonary veins, so LA cannot push blood into the left ventricle. So his only way is to push back into the pulmonary veins. So there is retrograde flow into the pulmonary vein system. Instead of pushing the blood into the left ventricle, he will push back into the pulmonary veins retrogradely. So there is A wave duration is increased in the pulmonary veins rather than the mitral A wave. That's why we have said earlier that if the patient is having an A wave, AR wave duration is higher than the mitral A wave duration, which is actually greater than 30 milliseconds, it indicates a high filling pressures. It is in this case actually the blood pushed back into the pulmonary veins rather than into the LV. So in some patients, this phase can be reversed. Okay, by giving medicines to this patient, we can reduce the preload by using diuretics or that kind of pharmacological agents. We can reduce the preload to the patient, and which actually can clinically improve the patient condition and brings the diastolic dysfunction into further lower stages like grade 1 or grade 2. By giving the medicines, we can bring the patients into grade 1 or grade 2 rather than staying into the grade 3. So some patients, this can be reversed by reducing the left atrial pressure and the left atrial and ventricular pressure gradient. But in some cases, they are not reversible, which cannot be reversed by any kind of treatment or something. They will be having a moderate to severe symptoms. So that's all the stages of diastolic dysfunction. Now we are talking how the display will be look in case of the diastolic dysfunction. So this is the normal diastolic function, and in this patient we will get a mitral inflow which will be looking like this. This is E wave and this is A wave. Okay, and this patient, by his age, or it is done when he was a 20-year-old. Now he is a 50-year-old man, and he did his echo once again, and he will be showing a tetradoppler display like this. Okay, Now what we can see, the E wave is reduced because of the left ventricle relaxation is not happening very well. So the E wave is reduced. So to compensate the loss of diastolic filling, the atria contract as much as he can. So the A wave is increased. So the ratio between E and A will be less than 1. Okay, and also the deceleration time, the time taken to decelerate and get back into the baseline is greater than 200 because the pressure is relaxed very well and pressure is brings up into the baseline very slowly. And now this patient have some other cardiomyopathy and other symptoms. He went into the grade 2 diastolic dysfunction. So what happens? His atria kind of mimic that he everything is going well with my ventricle, and I am trying to make this work, make this relationship works. So he tried to increase his pressure so that the E wave is restored back. It looks like a normal. That's why the name pseudo normalization. It's looked as same as of the normal patient. So um, here E wave is increased and the A wave is reduced, and E by A will be the normal limits. Okay. Now we advise this patient to Valsalva. I will ask him to close his mouth and mouth and nose and try to breathe into that system. And now I can see his E by A is reversed. Okay, that's what we have talked about earlier. In grade 2 diastolic dysfunction, while doing Valsalva, it gets back into reversal, E by A reversal. So the patient is actually having a grade 2 diastolic dysfunction. Only his atria is trying to mimic a pseudo normalization. While look at here, this patient is having a normal diastolic function, and while doing Valsalva also, it remains same. Like only a reduction, there is a small reduction, but not E is not that much lower than the A wave. So that's what happened in the Valsalva in normal patients. Okay. Now he got adversed by a reversible grade 3. He went into a grade 3 diastolic function. Here what we can see, the atria try as had to increase his pressure, his or her pressure, and now the blood is very pushed very actively into the left ventricle, and so that the E wave increases, but immediately it falls back because of the rapid equalization of the pressure between the two chambers. And also A wave is reduced because atria cannot contract very properly. Okay. And this patient I am advising to do a Valsalva. So here we see a similar, very similar spectral display. Only the E wave is much more higher here, but most cases we will see a similar thing, and we advise the patient to do a Valsalva. And Valsalva, here we can see that it falls back into the grade 1 diastolic dysfunction, similar to a grade 1 diastolic dysfunction. So this is a reversible case of a grade 3 diastolic dysfunction. This patient, if he is given enough pharmacological treatment and by the cardiologist advice, he can be brings back into grade 1 or grade 2. Okay, but here look at this, the same. It remains the same by Valsalva. Even after Valsalva, the spectral Doppler display remains the same. So this is a non-reversible case. So here the LA pressure is normal, and also in impaired relaxation, that is grade 1, it is normal. Here a small increase of the left atrial pressure is there. That's why the pseudonormalization. And here the pressures are much more higher in left atrium, and here very higher. And what we see in the tissue Doppler, as we go into the end, look at the magnitude. The amplitude is reducing considerably, and which means it is very small in the last cases. Now this is the actual echo images what we will be seeing. So here it is a normal case, and here there is a E reduced and A increased. Here there is a normal display, but by Valsalva it will be reversed. And here also A wave is increased, but with a rapid equalization, rapid deceleration. So here deceleration time is this much, and while here it is a very small deceleration time. So that's a grade 3 diastolic dysfunction. And also look at the E dashes of this patient. Here, this is amplitude is nearly at the 10 centimeter per second, which is 1 millimeters. Sorry, 10 centimeter per second. And here, when going to till here, it is almost nearly to 5 or 3. Okay, it is reducing. And now again the same thing, impaired relaxation and pseudo normalization, and here a restrictive filling. You can see a very higher E wave and very small A wave. Okay, and also a very rapid deceleration. The deceleration time can be measured from here to here. And here look at here pulmonary veins. This is a normal patient. He has almost a similar S and D. which is a systolic and diastolic waveforms. And here it is also an impaired relaxation, and the pulmonary vein is not affected in case of the impaired relaxation. So also S is greater than D, but here a diastolic dysfunction happens, which means a grade 2 or grade 3. S is very smaller and the D is very higher. So S is S less than D, which means a diastolic dysfunction for this patient. And this is actually the renewed diastolic function grading in case of according to the ASC. So we have to calculate three criteria. Okay, we should take the three criteria, which is we should measure E dash velocity. The septal E dash should be less than 6. Sorry, if the septal S dash is less than 6 and if the lateral S dash is less than 7, or an average value, the plus 6 plus 7 divided by 2. That how we calculate the average away. Okay, so the average value is less than 6.5, or if the increased E by E dash value, we get a E value, and if we get a E dash value, we divide it and we will get a value of 15 at septum, lateral value of greater than 13, and average value of greater than 14. Please by heart all these values. Okay, it's very important, so please by heart all these values. Increase the TR velocity, which is greater than 2.8, or at PASP, which is actually calculated by the TR velocity gradient equation. So it is 35. This much as values has to be taken care of, and if we are getting a value less than 6 and less than 7, and greater than 15, or greater than 13, and greater than 2.8 and greater than 35, now we have to check that if all the values is normal, like this is not all, the values are not that much less, or this is actually the dysfunction case. Okay, if the patient is having this much of value, the patient is having dysfunction. If it is not true, in this case the everything is normal for this patient. If the patient is having a higher values than this, and if the patient have reduced value than this, if the patient is have lower value than this, the patient is having a normal diastolic function, and the patient also having a normal left atrial pressure. So everything is normal in the first case. So second case is if the E dashes are only the thing that is reduced. Okay, all the other values remains normal, only the E dashes are reduced. Now we have to look the E by A of the patient. We have to calculate the E divided by A value. If it falls below 0.8, the patient may having grade 1 diastolic dysfunction, but he will be having a normal left atrial pressure. And second case is, third case is the patient is having a increased TR velocity and PASP, or increased E by E dash velocity, or any two, either of two abnormal values from this. Okay, any two is accepted, and one is rejected. Okay, now in that case we have to look for three more criteria. Okay, that is pulmonary vein Doppler has to be obtained if the S is less than D, and if the left atrial strain during the reservoir strain is less than 80, and left atrial volume index is greater than 34. So if this much of value is also true for this case, the patient has other diastolic dysfunction. If the more than one value is present, if the patient may have increased left atrial pressure, and we have to look for two more things to know grade 2 or grade 3. We have to look for E by A value. E by A value is if it is less than 2, it is grade 2. If it is greater than 2, it will be grade 3 with the marked left atrial pressure increase. Okay, it's very confusing actually, but we have to go through this checklist every time we have to do while we doing an echo. Okay. Now alternatively we can do the IVRT. If the IVRT is less than 70 also, we can calculate this. And now this patient is having any of this, he's not having any of this, and he will be having a normal LA pressure and grade 1 diastolic dysfunction, but he's saying he's very symptomatic, he cannot walk even a step. So we have to do a diastolic exercise test. Okay, actually I'm not talking about exercise test right now because it is a very other topic. You will be talking about in the stress echocardiography chapter, but I have to give a general idea, which is the patient is walking, the patient is coming to the OP, and you are doing the echo for this patient, and he's getting all the normal values for his echo, and but he's insistently saying that he's getting the symptoms of all kind of dyspnea and shortness of breath. Now we put him into a treadmill test, okay, or a bicycle ergometry or any kind of thing. There are two types of stress echocardiography. Actually, one is physical exercise, and other one is pharmacological exercise. Pharmacological exercise, we have to give him medicine so that the heart rate is increased. Dobutamine, adenosine, that can be done. but we advise for a TMT or something like that. So we do a baseline echo before the TMT, and after the TMT we will do another echo and get all the values, and we will compare both. Okay, the patient is having normal baseline values and a different or abnormal values during after the treadmill test, he will be having a grade 2 or grade 3 diastolic dysfunction. If he is having normal values even after the treadmill test, he will be having other symptoms, like he will be having other issues for this symptom. Okay, that's how we do it. So there is this exception in this flow chart, which is during in case of mitral annular calcification for MR patient, for MS patients, atrial fibrillation patients, and left ventricular assist device, which is used for increasing the pumping of the heart, and non-cardiac pressure, hypertensive patients, and pericardial constriction patients. These are the cases where we cannot do the whole chart, where we can skip something and can take some other things. Okay, I'm not dealing about that much details about that thing here. Anyway, okay, actually that's all about the presentation, and it took much more time. Do you have any questions right now? Any doubts?
No.
Are you clear? Okay. Do you have any do you do any practical cases at the hospital? Any of you doing practical cases at hospital? Shafila,
Yes, ma'am.
okay. Come again.
Yes, we do have a practical posting, so we sometimes do some cases over there in the hospital.
Okay, very good. So now what you have to do is when you are getting a patient, please kindly do all through these measurements. Okay, I don't want you to be very excellent in the what you do, but just go through all these measurements. You should take a E by A value. You should take a TDA value. You should measure the IVRT, and kindly bring all of that things into your system. That you have to, that when you are getting a job as a echocardiographer, you will automatically will be very fluent with the system. So and to understand all these values, and it will be very confusing for the first time. So we have to be practically very fluent. After that we can get into the values. Okay, that's how we do it. So don't get very confused. It's very simple actually when we are practically fluent with the system. So don't get confused. It is actually a very wide topic. Okay, so in this 1.5 hours it will be very confusing for you all. So anyway, I have done a 5 MCQs. I'm not sure that you can answer this, but try maximum. Okay, I will help you all. Okay, 1 second. After that we can wind up. Okay. Okay, the first MCQ is LAVI, that is left atrial volume index, is more than what value is the independent predictor of the mortality in death in a diastolic dysfunction patient. You are getting some values here, and if the left atrial volume index you are calculating, and more than which value, it will be an indicator of the mortality. Any idea? We have already talked about it earlier, and it's actually 34. Okay, this is a very critical value. You have to by heart it. If the left atrial volume is higher than 34, the patient will be having a very very big LA, and it is indicates the mortality rate. It increases it is a predictor of the mortality of the patient. Okay. Now, which of the following signifies the grade 4 diastolic dysfunction? All except. Okay. So we have given some criteria. So the deceleration time here, it is shown as 90. Actually, the normal deceleration time is 160 to 240. Here the patient is having 90, so it automatically falls into grade 4 diastolic dysfunction. So it is not the answer. Now E by E dash is 14. So we have already talked about here in the flow chart here. The E by E dash average is, if it is greater and equal to 14, it will be a grade 3 or 4 diastolic dysfunction. So it is also not the answer. And now D is greater than S. It is also if the D is greater than S, it is showing a diastolic dysfunction. And AR minus A, that is AR duration minus A wave duration, it is 24. So it is actually 30. The value is 30. If it is less than 30, it's actually a normal patient. The patient will be having a normal or nearly normal or grade 1 diastolic function. So never grade 4. If it is greater than 30, it will be grade 4. So this is the actually the right answer. And VP is the color and mode thing, the thing that we have already talked to put the M mode and that kind of thing. And it is if it is less than 45, it is actually grade 4 diastolic function. And here we have discussed it 3 times. So it's actually a Valsalva maneuver done for a patient. He's shown a E by A value like this in the spectral Doppler display during the rest, and he done the Valsalva maneuver, and here it went. So it is actually a grade 2 diastolic function. Never get confused. It's actually the pseudo normalization, and in pseudo normalization and grade 3 diastolic function, you should make sure you did a Valsalva. In case of grade 2, we have to make sure it is not the normal diastolic function, it is a grade 2. And in case of grade 3 diastolic function, the Valsalva is done to know which is reversible and which is not irreversible. Now, name this condition, and this is a higher level thing actually. Here we have seen that lateral E is this much and the spectral is this much. While we are seeing this value, you have noticed that the septal value is lesser and the lateral value is higher. It is almost like that for every patient. If you are going to daily echo, the patient always have a septal value lower and the lateral value higher. Okay. In here, this case, the lateral value is lower and the septal value is the higher one. So this patient is having a condition called constrictive pericarditis. Okay, in constrictive pericarditis, this condition is the pericardium get thickened. Okay, I have already told you that the lateral wall is actually a part of the outside of the heart. Okay, the pericardium is a part of the lateral tissue, lateral annulus. So if the pericardium is thickened and stiffened, it affects the lateral tissue Doppler, and it will be a very lower value. So if you are seeing a lateral tissue Doppler very lower than the spectral tissue Doppler, this patient may have constrictive pericarditis, and it is also known as annulus paradoxus. The condition is called annulus paradoxus. And which of the following is the IVRT? Here we have seeing a A and a B, and I want you to answer which is the IVRT actually. Okay, I have already told you that in case of TDI, you should make sure that TDI is when you are seeing a blue and red flow here, it's actually a TDI preset is on. So in the case of PDI, the upward flow is the systolic flow. Okay, here the systole ends. Okay, IVRT is the phase between the between the aortic valve closure to the mitral valve open. Okay, here E wave happens, so mitral valve opens here. So between the S and the E is the IVRT, and here between the A wave and this is the E dash. Okay, A dash. Okay, and this is the systole. Between the mitral valve closure to the aortic valve open, it is called the isovolumetric contraction time. It is actually a phase of systole, not the diastole. Okay, so don't get confused between the IVCT, isovolumetric contraction time, and isovolumetric relaxation time. This is the isovolumetric relaxation time. While measuring, do not measure this thing. Okay, always measure this thing. I think that's all about my presentation. Yeah. Oh, somebody, Puneet, well done. You have answered the answer for the left atrial volume index. Oh, somebody is getting things that I'm happy. I'm very confused that you are not getting anything from the slide, actually. Is Shafi here?
Yes.
Yeah,
Shafi, talk.
Yeah, Abhishek will give you a vote of thanks, okay? He's my colleague.
Does anyone else have any questions? Anyone has any questions?
Yeah,
please. Any questions? Unmute and ask.
If you have any doubts regarding the phases of LS treatment or anything, you can unmute and ask.
If you have any question, if you are shy to ask, raise your hand. At least I'll ask. Anyone? Well.
I think they are.
I had one question. How do you report the LS strain whenever it is reduced in the hospital?
What?
How exactly do you report when LS strain is reduced? How do you write it in the report?
Okay, we have this in our hospital. We have this criteria for a heart failure patient. So we do a HF protocol for a heart failure patient or a patient having a symptoms of heart failure. We do a heart failure protocol for this patient. For this patient, we will do all the criteria that we have already talked about earlier. We will take all the measurements for this patient, and there is first we will mention the chamber size of the patient, like the LA, LV size, RA, RV size. If the chambers are normal, we will tell chamber size is normalized, and we will tell about the systolic function of the patient. If there is there any RWMA for this patient, or this patient is having any systolic dysfunction, we will mention about it, and we also do a left ventricular speckle tracking, which is actually global longitudinal strain, which I think we will be covering it. Okay, we will measure ejection fraction of the patient from the T-course method, and then we will do the strain of the left ventricle, average global longitudinal strain, and after that we will do a area length method. And all these criteria are taken for this patient who have the symptoms of heart failure. After that we will get into the diastolic function of this patient. For a diastolic patient, we will take E by transmitral inflow, like E velocity, E by A velocity, deceleration time, and after that E dash is velocity, septal E dash velocity, lateral E dash velocity, and E by E dash velocity. That is transmittal E divided by the TDA E dash, and the values mentioned. And after that, we will mention the IVRT of the patient. What is the IVRT value of this patient? And VP of the patient, color and mode VP of the patient, and LA strain patient, LA reservoir strain. Actually, we are only doing the left atrial reservoir strain value. If it is having a value less than 18, we will mention what is the value we are getting by the software. We will mention it like the left atrial reservoir strain is this much, and also the LA volume. We are not using the LA volume indexed value. Actually, we just mention the left atrial volume. Actually, if it is less than 40, sorry, if it is greater than 40, the left atrial volume is increased. So ideally we have to take the indexed value because the body surface area matters very much, but we are not doing that currently. So that's what we do in the diastolic function of the patient. And we use the GE machine, and in this GE machine, we have the software specifically for the left atrial strain. So you just take a perfect left apical 4-chamber view and apical 2-chamber view, and just adjust the track poles. The machine automatically detects. That's the beauty of the AI. It actually detects everything, but we have to make sure the tracking is exactly same. He has not get into the pulmonary veins or left atrial appendage. Just make sure and get a go. Do a process, and it will automatically give you the value. Okay.